Okay, welcome to the Boston Scientific Symposium of EBC Live 2020. As you can see, the three of us are live, so we're not recorded. That gives us extra opportunity to make this symposium interactive. What we plan to do today is to talk a little bit about the optimal left main trial. That's a randomized trial of intravascular ultrasound in the left main. We've been hearing through the meeting today how important imaging is in improving our left main results. And this trial is a randomized trial sponsored by Boston and by Philips. And the three of us, Chima, Luca, and I, are the PIs of the investigation. I'm pleased to say the trial has survived and fought past COVID and is already recruiting, particularly in Dr. Testa's lab, who's been an absolute star in recruiting cases. So in the next 30 minutes, we're going to discuss some of the rationale for the optimal trial, and we're going to discuss some nice cases that Luca's got to show us. We're going to start off with a talk from Chima, who's going to talk to us about IVUS guidance for the left main, why we do it, and how we should do it. Chima, thank you very much.
Okay, thank you, Adrian. Okay, as Adrian presented, we are talking about the main PCI and particularly about IVUS guidance. And before just dealing with cases, and I'm going to do some introduction and talk about the rationale for optimal. No? We need to optimize the most result of the PCI and the left main. We have been living like a storm in the debate between PCI and surgery in left main disease, and it's truly very important to optimize by our side from the PCI perspective the results. And intravascular imaging plays a crucial role in this objective. IVUS is going to be really useful because it's helpful to plan the strategy, to prepare the plaque, to size the devices that we are using during the procedure, and finally to optimize the results by assessment of expansion, apposition, stent edges. For example, the selection between provisional and two stents technique can be done with the use of imaging. For example, we have here the criteria for IVUS. If we examine the circumflex and we see MLA over 3.5, low pearl burden, we can go to provisional. But if the circ is an important vessel with less than 3.5 lumen and more than 50% plaque burden, we should maybe go for two stents up front. In this case, with this very complex distal lesion and geographically very difficult to discriminate, it's very clear the disease in left main, LAD also involved, but circ is a mild disease, so we go with provisional for 16 LAD to a left main and pod with 5 millimeters and good result. This other case is a distal left main with proximal circ severely affected. With IVUS, we can confirm the distal disease of left main, but LAD has a lumen over 6. Then in this case, we are going to provisional, but from circ to left main in this case. This is not the most common, but sometimes happens. 328 and then pod with 4 millimeters and the result is very good. On the other hand, we have cases like this, very complex distal left main with involvement of everything, distal left main, ostial LAD, ostial circ. So two stent technique is the choice in this situation. Stent sizing is very important, and geography always underestimates. We can, I provide, for example, this is in our study we published in Neurointervention this year regarding the strategy for sizing in ostial and shaft in distal for provisional or in distal with two stents technique, usually based in the reference lumens in all cases. For example, this diffuse left main lesion, particularly distal, we size here the stent. This is the lumen of LAD 3532. Then the stent should be 3.5 millimeters in diameter. In this case, I showed before, we have this left main here reference. The distal is involved, but the proximal is more healthy. Here is for 1, and in circ is 3. So the stent is going to be 3 millimeters in diameter, but the pod should be done with 4 millimeters. In this distal lesion with more complex involvement, the reference lumen in the LAD suggests the use of a 4 millimeters stent, and in the circ is 3 millimeters the reference. So we are going to select two stents for this two stent technique, 4 millimeters to LAD, 3 millimeters to circ. And IVUS makes a difference in sizing. We have experience that with IVUS, you usually select a larger stents, as we can see clearly here in this data from a huge number of patients, but also we dilate more with larger balloons. Optimization is the next step. After sizing, implantation, we need to optimize these are the different steps we follow and the different criteria we have established. You can really find out this criteria in the publication. But I'm going to be in detail with the optimal. The optimal trial has this very elegant set of criteria: a position expansion, dissection in the edges, lesion coverage. And I'm going to illustrate with these drawings. Dissection, we tolerate those that are very short and very small in circumference. For complete apposition, they should be very short and very small, less than 0.4 millimeters. For optimal expansion, we have established a mandatory criteria, which is to be over 5, 6, 7, 8 for the minimum stain area in the corresponding circle, LED, POC, and the main, or the desirable targets of more than 90% of expansion with respect to the luminal area reference in LED main, LED, or circ. For example, in this case, we implanted a 3.520. We did the pod with 4, but even with that, we have this huge malapposition that angiographically is really not appreciated. And then with 5 millimeters, we have a good apposition. This is a stem circ to LED main, and not good expanded initially. It's only 7 square millimeters, but after good expansion, we get much higher, 9.7 square millimeters. In this complex distal LED main lesion, we treated with 2 stents, with kiss and balloon, with repot. We could see that in the intermediate step, the expansion in the distal LED main was not optimal, 76%, but we corrected this to 97% with the IVUS control. I can tell you that with angiography, these are the subtle differences that you cannot really distinguish. We have, in this case, a full LED main coverage, symmetry neocorina, and expansion over 90% in LED and circ. Meta-analysis show consistent benefits for IVUS regarding MACE, but these are registries, and it's important to move forward. In the Excel trial, another hint was that the comparison between high and low tertiles of minimum stain area showed a very different outcomes at 3 years in favor of the larger lumens. In the novel, again, the IVUS guidance was associated with a trend for less MACE, a significant decrease in TLR, and the comparison between tertiles, the higher and lower tertiles for MSA, a significant difference in, very huge significant difference in TLR, and an important trend in MACE. The British registry, Adrian is one of the co-authors here, and they analyzed a huge number of over 11,000 patients with LED main stenting, no imaging 6,000, imaging 5,000, this difference in mortality with an independent predictor role for IVUS in analysis. We also have shown this slide several times that showing that the use of predefined optimization criteria for IVUS increases the chances for less outcomes, improves the prognosis of patients undergoing PCI of the LED main. So we have so far this recommendation 2A, but we need to move forward, and the trial, the optimal trial, will be very important. Over 800 patients to be randomized to IVUS or angiography. Luca is enrolling so far nearly 20 cases. We are much lower with 3, but we are going for sure to accelerate and to improve the enrollment. It's not the best time with the COVID thing, but we will do our best. Then I was imaging for LED main disease is definitely helpful to evaluate the extension of disease, to characterize the plaque, to plan the strategy, to guide the preparation of the plaque, to size the devices to optimize results. And this is really good for patients and good for the prognosis. But the optimal trial will bring the ultimate evidence. Okay, thank you.
Kima, that was terrific. Thank you. Boston's recently brought out an HD IVUS catheter. Do you think it's given us better quality pictures, which are now sort of comparable to OCT?
I showed here one case that I did with the HD Boston IVUS, and I can tell you that it's really great. It's competitive, definitely, with RCT in the resolution. At least the resolution we need, of course, because it's not able to reach the 10, 15 microns of resolution, but we don't need so much. With the HD, we have enough resolution, and what is good, we have the complete vessel picture, because the penetration is still IVUS-like. This is important compared to OCT.
One of the reasons that people say they don't do IVUS pre is because they're worried that the patient won't tolerate the intravascular ultrasound imaging. What percentage of cases do you not do IVUS on because you're anxious and the patient won't tolerate it? Is that a big number or a small number?
No, maybe if when the lesion is very critical and the patient is in a bad condition, it's true that what you have to do is immediately open with the balloon, the lesion. Then once you have the patent and open the lead main with the less critical stenosis, and you have the hemodynamic stability, you can really do IVUS, or at least you can implant the stents and to check the stent result with the imaging. But you are right. Maybe in I don't know, 10, 20% of cases, I don't do IVUS baseline because the lesion is so tight that it's not really a good thing. But just to optimize, maybe I do in all of them because I think it's possible and safe.
Get the patient into a safe space and then image, and then
Yes.
get back into this kind of more slow, careful approach rather than this kind of rushing and trying to get the case finished over quickly. That's been fantastic. Thank you very much.
Thank you.
Well, Luca, I think you have some cases to show us. We're looking forward to
Yes.
it. And we'll perhaps ask Chima to give some comments as well once we see the cases.
Sure. So let me share my screen with you. Okay. Just a second to optimize sharing. Okay. Okay. I hope that you see what I see. Do you?
Yep.
Okay, good. So, well, just let me say for a few seconds that it's always a pleasure to share some time with you guys, and I mean it's also a pleasure to to share a couple of cases that I did in the last few weeks, and I hope that I'm gonna speed up the process even more. I'm not sure because mala tempora currunt, as the Latin says. Anyway, that's the case number one. 65 years old man with family history of coronary disease, have angina with progressive reduction of the exercise tolerance, and a treadmill test positive for both signs and symptoms. Echo normal parameters, nothing special. Mild stenosis of both internal carotid arteries, and then admitted for coronary angio. So the right coronary didn't receive much attention, a lot of calcium, but nothing really important. But the left main, of course, was a bit of an issue. And in this other view, you see there is actually also an involvement of the LCX in the osteoproximal part. So that was the syntax score, because of course we need to discuss, we need to sit down, we need to schedule the patient and see what is the best approach for this. I have to say that our team discussion was pretty useless, because the patient, a physician, by the way, firmly refused the surgical treatment, and he's actually a general practitioner working very close to my hospital. So there was no way to discuss with him. He said, just go with a stent or whatever, no matter what. Okay, that's good. Anyway, I would like to show you again a couple of pictures, a couple of movies actually, to discuss with you. So what is your strategy in this? Of course, you may think one stent, two stent, DK, culotte, tap, mini tap. What is your approach?
Chima, do you want to give us a comment?
Yeah, I am trying to figure out with angiography the osteon of LAD and CIRC are involved. It looks that the osteon in CIRC is more diseased more affected than the LAD osteon. In the projections, the disease is in the distal lead main, but the ostial LAD, of course, LAD is a bigger, important vessel, but the CIRC is not really a small vessel. And I think we need some imaging or something to see what's going on with the osteon of CIRC and LAD, because if one of them is well preserved, we should go with provisional to LAD or CIRC.
Oh, let me just say that for the sake of time, I didn't include in this presentation all the movies, but I can confirm what you just said. The lesion is particularly critical in the osteal LCX, but it's also significant in the LAD. Going back to the concept of IVUS at baseline, in this case, actually, I discussed with colleagues what to do, and with the colleague on the table, and I said, look, I will open up very quick, and then we'll decide what to do next. And yes, I have to say that it was not the case, because the patient destabilized immediately, as you can see from this.
Yep.
And so it was absolutely needed to put myself and the patient in a safe spot. So that's why I used this impeller, and then I actually went to the femoral approach. But anyway, so that was the situation. Sometimes happens. But anyway, putting the impeller actually put everything else really in a sweet spot. And my decision was to go straight to predilation, as we said before, you know. I mean, if you try, and we said that already, if you try with IVUS, you may destabilize the patient. And in my practice, I always do IVUS post, but I would say in a third of the cases, I don't do IVUS baseline. That's my approach. Of course, it's questionable. Anyway, this is what happened. So semi-compliant balloon, 2 millimeters to the circumflex to open up and give some flow. And then semi-compliant balloon to a 2.5 as a predilation in kissing balloon technique. And then a non-compliant balloon 3.5 for the left main. This is the result of the predilation. So you see that, you know, something good has been achieved already. And I would like to show you again this specific movie here. For some reason it stopped. Anyway, at this point, what is your strategy?
So I think the interesting thing is you do seem to have got balloon expansion. The other question I was going to ask was about the use of rotablation or lithotripsy. There's quite a bit of calcium there. And I think you're in a, you know, the key question, of course, is whether we're looking still for a 1 stent or a 2 stent strategy. I think for me, this is probably going to end up being 2 stents, but what do you think, Chima?
Yeah, I think the LED is pre-dilated, then the osteum has been touched. And now you could do IVUS because you have pre-dilated the lesions, but you have a space to see if the calcification is really worthy of some plaque preparation. You have the impella, and maybe a patient is more tolerant to a shock wave, for example, balloon, I don't know. But anyway, it's important to have the hemodynamic stability and now to do the plan more calm conditions.
I can tell that, of course, the patient was absolutely stable from hemodynamic. From an hemodynamic point of view, I mean, the impella is great. I don't know what is your experience, but in my practice, when I try to use it and I use it, well, it's I never regret. Yes. Sometimes probably is not needed, I have to say. Yeah. And that is also kind of a vogue nowadays. I use impella, whatever. Anyway, when you use it, you never regret. At that time, at that point, the patient was, you know, absolutely stable. But of course, he started to complain. Okay, is it taking a long time? Blah, 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 so forth. So my decision was to go straight to stenting to the LCX. And this is obviously questionable. We will discuss this, but that's what I did. And my intention was to go with a 2 stents technique with minimal protrusion to the LCX. I want to discuss with you this choice, in particular looking at the angle of the LCX. If you look at the angle of the LCX, I believed that it was absolutely suitable for kind of a T-stenting. Of course, guidelines and you know, experts, they suggest the DK crush, they suggest some more complex approaches. But I have to say, in that case, I felt very comfortable to start doing this kind of technique. What do you think?
It's true that the angulation is close to 90 degrees, which is good for T, and you don't have the complex of a lot of metallic thing in the distal main at the end. But the difference is, for example, culotte is going to be a problem because CERC is much smaller than the main. Then I think T or TAT would be the best here.
I agree with you. I mean, I have to say that I'm personally a fan of culotte technique, but not with this discrepancy. I mean, the left main is huge. The LED is relatively big. Circumflex is, you know, it has a big territory, big volume of muscle subtended and supplied by LCX, but it's not that big. So I decided, okay, let's keep it safe. The LCX, I just want you to remind that the LCX was badly diseased at the beginning. So I said, look, put the circumflex in a safe spot. And then I use a Megatron for the LED left main across the LCX. And that's these are the pictures. So the first one I chosen, actually I thought it was enough because my first intention was not to reach the osteo left main. This is also questionable. What is your practice? Do you always cover the osteo left main?
Well, the original data from France was very sort of persuasive that that's what we should be doing. I think the subsequent data has suggested if the ostium of the main is not diseased, you don't have to cover it, particularly when they're big. I think you sometimes create a problem then trying to get apposition of the stent. In a case like this, I probably would cover it as long as I'm confident I can get across. It does look as if there's a little bit of ostial narrowing, but as you've shown nicely in the LAO-cranial, if you're going to cover it, you cover it. You don't just miss it. So you've got to make sure you get it right.
Yeah, I have to say that usually I cover the ostial left main when, the disease is diffuse, even when there is, non-significant plaque, I tend to use it. However, when I have space and the left main is really tapered, because the ostium is very large, very big, I try to avoid this approach. But of course, I got no data to say that it was the right approach, but I have to say that the initial result actually convinced me that it was not a good idea, and I'll show you in a second. So after stenting the left main LAD, I did a kissing balloon, as usual. That's obviously mandatory, and that was the result. But if looking at LAO cranial, Adrian, you understand that you were right. You see? I hope that you can see. So, I mean, the leaving few millimeters of the left main, and geographically speaking, was actually not acceptable. So I said, look, okay, we still have time. Patient is fine. Everything is under control. So I will put another stent. And it was a Megatron 4.5 by 12. And I think that, I mean, this injection confirmed that it was absolutely, in the right place. Non-compliant balloon 4.5. I didn't do again the kissing balloon, but just the POT, because of course I didn't involve the distal left main, so 4.5. But that moment, of course, I did the IVUS, and I would like you to comment this. I mean, that's the first run from LAD left main, and I will let it go. It's not very long, so we got few seconds. But as you can see, there is a full apposition, nice apposition. That's the left main, and there are some numbers on the right side of the slide, and I guess it's it was okay. Do you want to see it again, or just go?
Probably
Okay,
in the
good.
interest of time, Luca, we should just keep going, I think.
Okay, that's the LCX, and I will show you just in a second. But anyway, this patient has been enrolled in optimal, so we made the calculations to make sure that the criteria were met. They were met, so that was the end. I used the Synergy Megatron for some reason that you know, but I mean, since I started my practice with this stent, I have to say that it became my workhorse for left main, in particular for two reasons: the increased overexpansion capability, but also for the uniform lesion scaffolding. I mean, it's really crucial for the left main, and I have to say that even outside the trial, I'm very happy to use this device. We were talking about the HD before. I did some cases with the HD since, for a few months. And I have to say that the difference between the HD and the normal one is actually 40 megahertz, is significant. And I agree with Shima when he said, look, this is something that can compare to the OCT. It's not like the resolution of the OCT, but definitely is a big step ahead. Okay, let me just show you the final angio. And I have to say, I was happy, patient was happy, and he'll come back in a month for a clinical control. Case number 2, 58 years old man, former smoker, hypertensive, dyslipidemic. Recent episode of breast angina, and treatment test positive for signs and symptoms, so sent for coronary angio. Again, the right coronary, not really interesting. The left main is the problem here. But not the left main, not just the left main. As you can see here, there is a bifurcation involved, and in RAO caudal, you see much better. Okay? Syntax score, even in this case, 24, but I have to say, I'm showing a second case where this patient, but not a physician, just said, do not cut my chest. I will never accept this. If you can do the bite stent, just do it. Okay, I said, look, I will, no problem. So what is your strategy?
My view, as I say always to my fellows, that the ostial disease is a left main disease, always. There is plaque in the distal left main. What happens is that here the plaque is more concentrated in the ostium LAD, but there is, which is severely affected, and the proximal LAD. And so the ostium of SIR should be evaluated, because maybe the provisional is the best here to LAD, left main LAD, and then to check the SIR afterwards.
I think you have to remember how much disease it takes to produce an appearance like that. you know, it's easy for us to forget. There's an awful lot of atheroma around the ostium of the LED there, which must inevitably involve the terminal left main. But I would agree with Chima. I think they're also trying to get a measure of what you think the size of the LED should be. Imaging would certainly help you there.
Yeah.
But you're going to be moving quite a lot of plaque. But I think you may get away with a single stent crossover into LED, I think.
Yeah. Okay. And I have to say that obviously I agreed. So again, this was a matter of time. In that case, patient said, again, complaining, jumping on the table and so forth. I mean, it was quite a lot of fun, I have to say, that case. Anyway, a lot of fun. So I said, okay, go quickly, good. 2.5, 3.4, and non-compliant balloon. So I just made sure that the lesion onto the proximal LED, I'm not sure did you know this, but it was subocclusion. Actually, I fixed it with a synergy 324, it was okay. I post-dilated with a 3, it was fine. So at that time I said, look, I got a big dissection. I hope that you can see in the proximal LED and left main. You see that?
Yeah.
It's visible in LAO. Okay, good. So look, the fellow very close to me said, look, let's do the IVUS. Yes, sure. With the dissection left, let's do the IVUS. Yeah, it was a very, very nice call. Anyway, said, look, let me put the stent and then we'll discuss for the rest of the afternoon and then we'll do the IVUS every time you want. Anyway, so patient was going down. So I said, look, I will put a stent, I will secure the situation and I'll post-dilate, I'll do the kissing balloon, men's side, and then we will check. I would like you to have a look at this. Of course, the numbers are on the right. And in this case, I mean, this patient has been included in the optimal trial. So this is a different IVUS, as you can notice. This is a Phillips one. So the shaft of the left main was not good, but also the MLA calculated to the LAD was not good. So according to what is, in my mind, best practice, perhaps is obviously our aim for the optimal trial, I needed to post-dilate. And so I did. 4.0 millimeters non-compliant balloon to the proximal and ostial LAD, 4.5 to the left main. And I did IVUS again. That's the left main, that's the ostial LAD. And it changed significantly. For the sake of time, I just skipped the entire run just to show you what it was and what it was at the end. MLA and 11 millimeter square and LAD 7 millimeter square. I would like to have your opinion because 7 millimeter square to the ostial LAD is something that, nothing to cheer about, but it's acceptable, it's good. I believe that with that huge plaque burden, 7 millimeter square, it's something you must accept. But, I finally achieved a good apposition, as you can see here. It's okay. I mean, angiographically speaking, you will never say that you could do, something even better than this, I guess, on the proximal LAD. However, it was 7 millimeter square, so it's not huge. What do you think? Would you have stopped here or not? I stopped. I say I
think if you've gone at high pressure with a 4 balloon, I'm not sure what else you're going to do, really. There doesn't appear to be a lot of calcium. I don't think, lithotripsy is going to help you further. So you're really going to be going for a 4-5 balloon, and then you perhaps run the risk of starting to compromise the circumflex. So I think you've got a very nice result with one stent, and I think there is a benefit from that in this case. Perfect is the enemy of good, and
I agree. Yeah. Indeed, I was actually in the mindset of getting out the lab quickly, making sure that all the IVUS goals were met, and also I asked myself what to do next. I mean, even if I take a bigger balloon, what is the point to achieve 8 and maybe I compromise the ostial LCX and then I have to put the stent on LCX? I said, look, best is the enemy of good, as you said, Adrian. Yes. And I think it's okay. It's okay.
The cutoff value for LAD and in the Excel trial was around 7, which is, you are right, you are in the safe point. And in general, it's 6 square millimeters, the cutoff for stenosis in vessels, not the main vessels like LAD. If you have any doubt, you can do one day pressure wire to check if the circ has some flow compromise, but not this moment. This is perfect result for this procedure.
I think it was okay. Thank you for saying it's perfect. But what I think at the end is, I mean, the take home from these two cases that IVUS should be part of the routine. We are saying that since the beginning of this meeting. Pre-specified IVUS goals are paramount. I mean, Chima made a very nice presentation. I mean, we need to have a goal. Otherwise, it's just a way to show off ourselves. Indeed, IVUS data must be actionable, absolutely actionable. And in the first case, of course, it was not needed to make additional actions after IVUS. But in the second case, it was absolutely mandatory to react to the IVUS numbers. And let me say that the optimal trial has been designed with this purpose. So we'll see in the future what we can get. And thanks for your attention. Let me stop sharing. Okay.
That was great, Luca. I mean, I think
you.
It's also particularly important, and when we're moving into these younger patients, you know, one was a 65-year-old, one was a 56-year-old, I think you said, that we spend the time to make sure we've done everything we can. Now, you know, the reality is we can't get a perfect result all the time. But the fact that you spent some time making sure that you know, you've got about a 30% increase in the proximal LAD area, that's going to be important for this guy. And particularly, you know, when you're in your late 50s, as some of us are, we can still occasionally go for a short run or something like that. And we need to, you know, our coronaries need to be as big as possible. So I think that was a really great result. So this has been a short seminar. We're grateful to Boston for their support. I think what we've seen is how using the HD IVUS technology that Boston now has, combined with the Megatron stent, with the properties that the Megatron has, how we can improve our outcomes, not only really in the elderly patients where, you know, stents may not be maybe the only option they have, but also in these younger patients now, we're really getting a fantastic result, which gives them a lifetime, hopefully free from angina, has got to be our goal. So we look forward to completing the trial, and we look forward to the rest of EBC Live 2020. Thank you very much. Thank you very much.
Thank you. Bye-bye.
Bye-bye. Bye-bye.